Greetings and welcome to BRCA and Young Women, What You Need to Know webinar. If anyone should require technical support during this webinar, please click the question mark icon on the top right of your screen. You can submit your questions throughout this webinar by typing them in the Ask a Question field on the left side of your screen. As a reminder, this conference is being recorded. I would now like to turn this conference over to your host, Pamela Klein, Outreach Manager for the Bassler Center for BRCA. Thank you. You may begin.
Good afternoon, and thank you for joining us for today's webinar. The Bassler Center for BRCA at Penn Medicine's Abramson Cancer Center is the only center in the world solely devoted to BRCA-related cancers. The Bassler Center supports cancer care and BRCA research at every stage, including communication, outreach and risk assessment, prevention, early detection, treatment, clinical trials, and survivorship. Dr. Edward and Merry Prostic have generously established this webinar as part of the Elizabeth Prostic Memorial Outreach Program in memory of their daughter. The following video is a tribute to Elizabeth, her incredible life, and her dream of creating communities that increase awareness about BRCA and metastatic cancers. The Bassler Center is proud to be a part of this mission by providing life-saving information and hope to individuals and families worldwide.
Tomorrow, bet your bottom dollar that tomorrow there'll be sun.
Lizzie Prostic was an amazing young woman who believed in the promise of tomorrow. And though her tomorrows were cut short, we can celebrate and sustain her optimism. Lizzie lived large. She loved the stage and brought it to life with her voice and her energy as a talented child and as she grew into a woman. Her world was full of loving friends and family, and success in class, in sports, with girls, and with boys. Sophomore year of college, Lizzie met Michael Lundblad, a liberal and an English major. He got a preview of her leanings when he saw her quizzing a friend about senators. But she learned to love camping. He learned about couture. And political opposites, Michael and Lizzie spent 10 years together, marrying their minds and their passions. Michael loved her boldness and her softness, her interest in so many different types of people, and ability to remember the small details of their lives. The time she made to talk with her grandmother, her pearls, her red shoes that said she was not afraid to be noticed. She was not afraid. Lizzie's intellect and drive were rewarded with exciting opportunities. She blazed through the University of Pennsylvania and into the halls of government, determined to win in every venue and for every cause that was important to her. Her work for senators and on committees quickly made her a Washington insider. She rose to Chief Privacy Officer and Senior Advisor to the Secretary of Commerce before being lured away to the private sector. Not yet a lawyer, she was named Managing Director at Sonnenschein, Nath, and Rosenthal in Washington, D.C., and was completing her law degree at night at George Washington University when she died. When Lizzie was awarded a posthumous degree at the law school graduation, the entire audience stood in tribute to her spirit. Lizzie was 31 when she was diagnosed with stage 4 metastatic breast cancer, and her daughter Harper was 4 months old. Michael did research. Lizzie didn't want to know the odds, expecting to beat them. But the cruel reality was that although breast cancer is generally curable, metastatic breast cancer is not. And they found little support to help them deal with the psychological and emotional realities they had to face. In her last months, Lizzie and her family began to envision an online support network that would show patients with metastatic disease that regardless of how long they have to live, they have the ability to control how they live. This was Lizzie's final cause, and one which will be honored. Lizzie wanted to see her daughter's first birthday. She didn't make it. But she lives on in the people who loved her, and through grants such as this one being made in her name. And in truth, none of us knows how long we'll live, so we all should listen to Lizzie and make the most of every tomorrow. Live large, live strong, and wear red shoes.
Today's program will discuss the unique considerations for young women with BRCA1 and BRCA2 gene mutations. You may type questions into the Q&A box on your screen. We'll try to answer as many questions as possible at the end of the presentation. Today's program will also be archived and available for viewing. I'd like to introduce our speaker, Dr. Susan Domchek. Dr. Domchek is a board-certified medical oncologist, the Vassar Professor in Oncology at the Perelman School of Medicine at the University of Pennsylvania, Executive Director of the Vassar Center for BRCA, Director of the Mary Ann and Robert McDonald Cancer Risk Evaluation Center at the Abramson Cancer Center, and a Senior Fellow at the Leonard Davis Institute of Health Economics. Dr. Domchek has committed herself to pursuing research related to genetic susceptibility to breast and ovarian cancer, particularly with regard to risk assessment, screening, prevention, and treatment. She is especially interested in the development of targeted therapeutics in this population, as well as the long-term impact of risk-reducing interventions. Dr. Domchek, the floor is yours.
Thank you so much, and thank you for this opportunity to present this important topic. We hope that by the end you'll have more information, and again, we're very happy to take questions and also feedback about what additional things we can include. So we're going to go through some of the basics about BRCA1 and BRCA2, talk about cancer risk and timing of prophylactic procedures or preventative procedures, discuss some of the unique issues related to reproductive decisions and hormone replacement therapy, which are a particular concern to young women, go through some of the more recent data about BRCA-directed cancer therapies, talk about some ongoing research, and perhaps most importantly, talk about various support resources that are available for young women. To review BRCA1 and BRCA2, these just stand for breast cancer 1 and breast cancer 2, and they are specific genes that are located on chromosome 17 here and chromosome 13 here. And these are genes that everybody has. And when you're born, you have most people have 2 normal copies of BRCA1 and BRCA2. And these genes make proteins which help damage DNA repair within the cell. And if you will, are tumor suppressor genes. They help prevent us from getting cancer. But when an individual is born with one bad copy or a mutation in BRCA1 or BRCA2, that individual has a much increased chance of developing cancer in adulthood. Men and women can carry BRCA1 or BRCA2 mutations, although because of the cancer spectrum, where breast and ovarian cancers are so common, this is most important. This is often most obvious in women. But BRCA mutations can be passed down to children, and if an individual, either a mom or a dad, has a BRCA mutation, the children have a 50-50 chance of having that gene mutation. Each child has a 50-50 chance. So what are some of the features of hereditary cancer? I'm sorry, there is a comment that someone can't hear me. If this is a comment from more than just this one person, please do some additional emails and we'll figure out the technical problems. The features of hereditary cancer, however, are that there's cancer in multiple generations and that there are cancers at younger ages, particularly under age 50, individuals who have multiple different types of cancer, clustering of rare cancers, and by rare we mean things like sarcoma, which happen uncommonly, and cancer in the less usually affected gender. Well, what do we mean by this? We mean male breast cancer as an example, which is men can get breast cancer, they just don't usually get breast cancer. And hereditary cancer can be more common in certain ethnic groups, particularly individuals who are of Ashkenazi Jewish descent. Now, not all BRCA-related families are really obvious. And why is that? Well, the risk is never 100% to develop cancer. So any individual who has a BRCA1 mutation, some women get lucky and don't develop cancer. Some families are very small or have very few women, and in that case, again, it can be hidden in the family because if there are mostly men or really just few women, then it can be hard to sort of see the risk of breast or ovarian cancer. In addition, sometimes the family history is not known, for instance, in a situation where people died of a young age. In addition, individuals can die young of other causes, like motor vehicle accidents or things like that, and therefore, if you will, did not become old enough to have developed a cancer. And sometimes women have their ovaries removed for other reasons. They've had a hysterectomy, for instance, for fibroids, and at the same time had their ovaries out when they were 40, and therefore they significantly reduce the risk of developing breast and ovarian cancer. And so sometimes these mutations can hide in families, and that's always a very important point. And recognizing both your dad and your mom's side of the family and also that structure of your family is actually quite important. So how common are BRCA1 and 2 mutations in the population? In the general population, about 1 in 500 or so individuals will carry a BRCA mutation. If you take all individuals with breast cancer, about 5%, and in certain populations maybe up to 10% of breast cancers are inherited. And for ovarian cancer, this is in the 10 to 15% range. However, if you look at individuals who are of Ashkenazi Jewish ancestry, 1 in 40 individuals has a BRCA mutation, and this is at least 10 times higher than in the general population. In addition, 3 specific mutations account for about 90% of all mutations. So let me explain this a little bit more. If you think about looking for a gene mutation, like looking for a spelling error in a very large book, there's lots of pages and lots of words that you need to get through. But in the Jewish population, there's 3 specific words in that huge book which are misspelled. And so you can go to those 3 particular words, and again, the vast majority of the time, if there is a misspelling, it's going to be in one of those 3 words. These are called founder mutations. And this is important because basically any individual who's of Jewish descent and has breast cancer has about a 10% chance of having a gene mutation. If you're of Jewish descent and have ovarian cancer, it's 30 to 40%. So knowing that you're of Jewish ancestry is actually really important in the consideration of being tested. Well, what are the lifetime risks if you have a BRCA1 mutation? Here we're going to start with women, and we're going to look at the risks for both BRCA1 and BRCA2 mutations compared to an average woman in the United States without a mutation. And as you can see, the risks of breast cancer are significantly elevated. Women with a BRCA1 mutation have about a 60 to 80% lifetime risk. Women with a BRCA2 mutation, 50 to 70%, and this is compared to a lifetime risk of about 13%. For ovarian cancer, women with a BRCA1 mutation have a 30 to 40% lifetime risk, and for BRCA2 about 10 to 20%, and again, much increased compared to the general population of 1 to 2%. There's some modest risks of increased risk of pancreatic cancer, particularly in BRCA2 mutation carriers, and similarly, a modest increased risk of melanoma. There are risks to men as well. For breast cancer, the lifetime risk of a man developing breast cancer if they have a BRCA2 mutation is about 5 to 10%, and for BRCA1, about 1 to 5%. But as you can see, an average man in the United States without such a mutation has a risk of 0.1%. So these risks, although still small from an absolute standpoint, are still quite elevated. There's a significantly increased risk of prostate cancer in BRCA2 mutation carriers, and these prostate cancers are more aggressive and tend to be the type of prostate cancers that, if you will, matter. You hear a lot in the news these days about some prostate cancers not causing a lot of trouble. These aren't those kind of prostate cancers. The risk of pancreatic cancer and melanoma are the same as for women. So how do we manage risk? Well, if we know that someone has a BRCA1 or 2 mutation, there have been a number of different guidelines that have been developed to address this. The first is that breast cancer screening starts at age 25. We often will delay the mammogram until 30, but we start the MRIs at 25, and also clinical breast exams are performed every 6 months. In addition, there are surgical options, such as the prophylactic removal of the breasts. However, in breast cancer, because we do have good screening, most cancers are found at an early stage, and most women survive their breast cancer. A reasonable option is screening. However, prophylactic mastectomy is the most effective way of making sure you are not diagnosed with breast cancer. This is a very personal decision, and people should really explore their options, specifically with regard to their plastic surgery options and reconstruction. There are also hormonal options, hormonal interventions to reduce your risk of breast cancer. There are medications such as tamoxifen and raloxifene, and prophylactic removal of the ovaries can also reduce the risk of breast cancer. In contrast, in ovarian cancer, unfortunately, although we do offer ovarian cancer screening with blood tests like CA-125s and ovarian ultrasounds, we really don't have a lot of confidence that these methods are particularly effective. There are some new things on the horizon, but at this point, ovarian cancer screening is not where we want to rest our hopes. There are also medications that you can take that can decrease the risk of ovarian cancer, and oral contraceptive pills are one of them. Oral contraceptive pills decrease the risk of ovarian cancer by about 50%, but there may be a slight increased risk for the development of breast cancer. Finally, removal of the ovaries and the fallopian tubes is recommended between age 35 and 40 after childbearing is complete, and there is the advantage of both having a decrease in the risk of ovarian cancer and in breast cancer. So with regard to having ovaries removed, ovarian cancer is in contrast to breast cancer because we don't have good screening. Most of the time, ovarian cancers are unfortunately caught at a late stage, and too many women with late-stage ovarian cancer do not survive their cancer. And for that reason, there's a very strong recommendation to have the ovaries and the fallopian tubes removed. One of the big questions is the question of timing, and one that might be right. And there are some differences between BRCA1 and BRCA2, for example, which we can talk about later. There has been a question about salpingectomy alone or removal of the fallopian tubes alone, and I will get back to that at a later time. For men, these are just the overview points. For men, we recommend starting self-breast exams, and sometimes we consider mammograms, although there's really little data to know when the right thing to do is. We do recommend prostate cancer screening beginning at 40, including PSA, which again, because this prostate cancer is more aggressive, so particularly for BRCA2 mutation carriers. Individuals who have a family history of melanoma and or pancreatic cancer should get a more individualized screening plan from their healthcare providers. There are no specific guidelines. However, skin exams are easy with regard to melanoma, and there are specific trials that are ongoing regarding pancreatic cancer screening, particularly in families with pancreatic cancer, involving things like endoscopic ultrasound. There's also some data that lifestyle choices can play a role in cancer risk reduction, and they clearly have other benefits as well in terms of helping with heart disease and bone health, and particularly for BRCA1 and 2 mutation carriers who are going to undergo menopause early due to removal of the ovaries. This is a really important aspect. So we strongly recommend that people maintain a healthy weight, not smoke, be physically active, and be moderate in terms of their alcohol intake. These are things that can be helpful on a large number of fronts. So we're going to talk about some of the common questions that we get with regard to mastectomy and oophorectomy. So first, the question of the mastectomy and whether screening is a valid alternative. This one is an important question because, again, as mentioned, there is not as good data that mastectomy confers a survival benefit. Again, because with MRI we often diagnose cancers at an early stage and most women survive their breast cancers. But this is a really valid option, and we'll review this in more detail. We'll talk about the timing of oophorectomy, more about oral contraceptives, the transmission of BRCA1 and 2 mutations, how cancer treatments might change, and some of the issues of how to talk to your children about these mutations. So let's get started with issues related to the timing of prophylactic procedures. One really important thing that we always like to emphasize is that when people hear about their lifetime risk of breast cancer, it very much feels like that risk is upon them all at once. So if you're 25 and you hear that your lifetime risk of breast cancer can be as high as 60 or 70%, it feels like all that risk is in the moment. So we find that these types of graphs can be really helpful to demonstrate to folks what their risks are per decade. And although it's a little potentially fuzzy here, what this represents is that in a BRCA1 mutation carrier, by the age of 30, her risk of developing breast cancer, as you can see, is very low in the 1 to 2% range. When you go up by age 40, you can see that now it's 10%, and by age 50, you're at 30%. But this just gives you an idea that sometimes we see women who are 25 and they're still interested in having their children and breastfeeding, and it is, although a very, very personal decision, sometimes this can be helpful to demonstrate that their risk over the next few years is actually not terribly high, and that might influence their decision making on the timing of their procedures. Similarly, for BRCA2, you could see that these risks are even lower at younger ages, with a risk to age 30 very low, of around 1%, and even by age 40, this is under 10%. When we get to ovarian cancer risk, one more slide. When we talk about screening versus surgical risk reduction, again, we know that this intensive breast cancer screening with MRIs may detect cancers more early at a more treatable stages, and therefore screening is a valid alternative. However, even in early stage breast cancer, women may require chemotherapy to treat that cancer, and that is then, as you can imagine, one of the factors that goes into this. The intensive screening is sometimes done in conjunction with other preventative medications, but again, the surgical risk reduction, the prophylactic mastectomy, is the most aggressive way to reduce the risk. The most important thing in my mind is that women who are thinking about this as an option should meet with plastic surgeons to understand their breast reconstruction options and the potential for their recovery time and what things can realistically look like after their procedure is done. On the second aspect, in terms of timing of oophorectomy or prophylactic removal of the ovaries, these are additional curves that you can see, which is the risk of a BRCA1-related ovarian cancer is almost undetectable by age 30. By age 40, you are still in the range of 3%. When you're up to age 50, it's 10%, and you can see it move on from there. In addition, you can see for BRCA2, the risk of ovarian cancer, even prior to age 50, is actually quite low. This can influence how people think about their timing of their oophorectomy. So on the one hand, we don't have effective ways to screen, and we know that the ultrasounds and the CA-125 are both not very sensitive, meaning that they don't pick up cancers at an early stage the way we want them to all the time, but they're also not very specific, meaning that there's a lot of false positives. We also know that BRCA1 and BRCA2, although we tend to sort of think about them together and we think about the same way, you can see that the BRCA1 mutations have a higher risk of ovarian cancer and at somewhat earlier ages, and BRCA2 relatively lower risk of ovarian cancer and more typical ages. So this may well influence decision making. In addition, if you are someone who has a BRCA2 mutation and you've already chosen to have a mastectomy, you're not going to get the same additional benefit of having breast cancer risk reduction from having your ovaries removed. And therefore, that can impact how you're thinking about the timing. So let's talk about just taking out the fallopian tubes. This is a very active area of research. Why are we thinking about this at all? Well, there are some data that many, not all, but many ovarian cancers appear to arise in the fallopian tube and then go to the ovaries. One of the big questions is what percentage of ovarian cancers arise in the fallopian tubes. And at this point, the best data suggests that maybe it's 60 to 80%, but we don't really have a good number for that. As you can see, that still leaves a reasonable number of cancers that may not arise in the fallopian tube. The idea is if you remove the fallopian tubes before there's cancer in the ovary, then maybe that's all you need to do, and you can leave the ovary intact. However, we actually also don't know, even if it arises in the fallopian tube, we don't know when those cells go from the fallopian tube to the ovary. And so we don't really necessarily right now have a good idea on the timing of that. So we don't have a good level of evidence. We can't right now tell people it's fine to get your fallopian tubes removed and you'll be okay. And it's even hard to say you should get your fallopian tubes removed and get your ovaries out later on the basis of the current evidence. But people are working on this, and there's actually a big project ongoing in British Columbia, not specific to BRCA1 and 2 mutation carriers, but just looking at all comers, where women who are having a tubal ligation, so their tubes tied, or having their uterus removed for any reason, but planning to leave their ovaries in place, have their fallopian tubes removed. And we'll be able to see whether that decreases the risk of ovarian cancer over time in that population. So should you do this? Well, the devil's really in the details, and it requires a very detailed discussion of pros and cons. In general, I want to be clear, this is not considered a standard of care. However, I have had some young women who have BRCA2 mutations, and that's really the one place that I may think about it, who've already had mastectomy. So again, removing the ovaries is not going to have added benefit in terms of breast cancer risk. They've finished having their kids, and they're actually even considering a tubal ligation, and they're 35. Well, in that case, it makes good sense to consider, instead of a tubal ligation, have your tubes removed and then potentially have your ovaries removed at age 45. So it's that type of detailed discussion that has to occur between patients and their doctors, because it is quite a complicated issue. And I spent more time on that because people are specifically asking questions about it, but I'd be happy to answer more at the end as well. Well, what about reproductive decisions and hormonal replacement therapy, which are obviously quite important topics as well? First, let's talk about oral contraceptive pills and the way that we think that these work in terms of being associated with a decreased ovarian cancer risk is that prevention of ovulation may be associated with this decreased risk. And studies have suggested that the risk reduction for ovarian cancer can be as high as 50%. There have been conflicting studies on the impact on breast cancer risk, and there have been some studies that have shown a small increased risk in breast cancer. It's important to remember, though, that there are good and bad things about birth control pills in addition to cancer risk. A good thing is obviously the prevention of an unintended pregnancy. A potential bad thing is blood clot risk, which we know is associated with birth control pills. And so our strategy on this is that people must balance their personal need for birth control pills against these other cancer risks. And so if someone really values taking birth control pills to prevent unintended pregnancies, to regulate their cycles, there's no contraindication to doing so. again, it requires a discussion about individual preferences and risks and benefits. Pre-implantation genetic diagnostics. So what is this? This is a process by which people can go through in vitro fertilization and then screen the embryos and only reimplant the embryos that do not have the gene mutation. This is obviously not a requirement for anyone, and as we like to say, some people think it's great and some people think it's evil, and we are just the messengers that like to tell people that this technology is available. So this is a way to minimize the chances that your child might have a BRCA 1 or 2 mutation. PGD is expensive, and insurance may cover some of this, but this is, these are very personal decisions, and there are many centers of excellence that can provide you more detailed information about this option. What about hormone replacement therapy? We know that removing the ovaries abruptly and surgically can put a woman into abrupt surgical menopause, which can be uncomfortable from the standpoint of quality of life, hot flashes, night sweats, sleep disturbances, vaginal dryness, feeling a little mentally fuzzy. All of these things have been reported. In addition, the estrogen deprivation at a young age can accelerate bone loss and appears to also increase one's risk of heart disease. And women who have a BRCA mutation and no prior history of breast cancer have the option of receiving a short hormone replacement therapy, which we usually continue until about 45 to 50, 50 being around the time of natural menopause. Women who have previously had breast cancer, generally we do not use hormone replacement therapy, and we try to use other things to help mitigate the side effects from a quality of life perspective. There are medications that one can take, like Effexor, that can decrease hot flashes, and acupuncture has actually been shown to be reasonably helpful for that. One other point I want to make about hormone replacement therapy is that women who have their ovaries out at age 40 to prevent themselves from getting ovarian cancer, when you think about it, they were making estrogen when they started. And so replacing the estrogen back to make it more palatable to have that surgery is completely reasonable, and we really don't ever fully replace estrogen doses. We also do have data that there's a decrease in the risk of breast cancer, which is not increased by taking hormone replacement therapy back. So it's an absolutely reasonable option and should be discussed with your providers. Let's now talk about cancer care and targeted therapy. So these are for young women with BRCA mutations who've been diagnosed with cancer. And some individuals have their genetic testing. In fact, too many individuals have their genetic testing after they've already been diagnosed with cancer. But the results of this testing may impact your cancer treatment. For instance, we know that people who have a BRCA-related breast cancer have an increased risk of developing a breast cancer in the other breast. This depends on how old you are when you're diagnosed and whether it's a BRCA1 or BRCA2 mutation. But because of this increased risk of what we call a contralateral breast cancer, in BRCA1 and 2 mutation carriers, there is a discussion about removal of both the breasts to minimize the chance of developing a breast cancer on the other side. In addition, there's a lot of active work looking at whether there are particular therapies that might be more effective in BRCA carriers, and two of these are a type of chemotherapy called platinum and then drugs called PARP inhibitors. PARP inhibitors are a new type of drug. They're not really chemotherapy drugs. They're a new therapy that basically block certain enzymes called PARP, and they inhibit these. And basically what happens is that PARP helps in the repair of DNA damage in the cell. And if you give PARP inhibitors to normal cells, not much happens. And the reason not much happens is because the cell can repair the DNA in other ways. But if you give a PARP inhibitor to a cell that is a cancer cell, because of a BRCA mutation, that cancer cell has lost both of its copies of BRCA and actually already can't repair DNA damage very well. So when you mix the two things together, PARP inhibition in cells that have absent BRCA 1 or 2, the cells don't do very well. And so there's been many PARP inhibitor clinical trials that have been ongoing, and I'm going to talk about two that are ongoing right now. They're not the only ones that are ongoing, but it's just to give you an idea of what's out there. The first PARP inhibitor, called olaparib, was approved by the FDA in December of 2014 for late-stage ovarian cancer patients. There are no PARP inhibitors currently approved in breast cancer. So this is an example of some of the studies that have been done. One looked again at this drug called olaparib. There's several others out there, rucaparib, veliparib, but this particular drug was used in BRCA-related cancers such as breast, ovarian, pancreatic, and prostate cancer. And there was about a 26% response rate overall. These were women and men who had advanced cancers that had progressed on multiple lines of therapy, so a more advanced setting, and again approved by the FDA in December 2014 for advanced stage ovarian cancer. And the hope is that these drugs will be taken into earlier stages and therefore be effective for more people and also lead to a decrease in the risk of cancer returning. So let's talk about current research and how we're trying to do better with all this, because honestly, we don't really love our current strategies here. The first thing is that we are very interested in vaccinations and immune therapy. If you've been paying attention to the news media sources lately, there is a lot of discussion about immunology to treat breast cancer and lung cancer and melanoma. And in lung cancer and melanoma, these drugs are extremely effective. We're still trying to figure out the best ways to use these drugs in things like breast and ovarian cancer. But there's also another strategy, which is to try to prevent cancer from developing in the first place by using a vaccine. And again, we'll mention a specific study in a minute. We're looking at these other targeted drugs and therapies, including PARP inhibitor, and looking at why certain tumors develop PARP inhibitor resistance. We're also trying to figure out the best ways to get people to get genetic testing. We really want expanded access so that people can get the genetic testing that they need. And we really want to know how to best have folks talk to children about genetics and cancer risk. One thing I will say is children know more than you think they do, and they learn a lot about genetics, and sometimes they surprise you with what they know. Talking a little bit about vaccination, there's an ongoing clinical trial here at Penn, and there are others out there in other places, but right now what we're doing is looking at high-risk patients with breast, ovarian cancer who've already had all their therapy. They don't have disease that's spread outside their breast or their ovaries, and they're in remission, and then treating them with a vaccine. And the hope is if this looks safe and develops the correct immune response, we're going to look at it specifically in BRCA mutation carriers. That's the type of work that we feel is important to do. A study in advanced breast cancer patients, one looking at a PARP inhibitor, is called Olympiad, and again, there are others that are also enrolling. The important thing here is to talk to your oncologist about the potential options for different therapeutic trials. So this is comparing olaparib to traditional chemotherapy in BRCA 1 and 2 mutation carriers who have metastatic breast cancer. Another study called the Olympia study, I don't make these names up by the way, looks at one of the PARP inhibitors as an adjuvant therapy. So these are women who have BRCA-related cancer who have had their chemotherapy and they don't have any evidence of cancer anywhere else, and they're treated with this PARP inhibitor versus a sugar pill to see whether or not giving this PARP inhibitor will work. The drug itself is only given for a year, although people are followed for 10 years. And right now it's restricted only to triple-negative BRCA mutation carriers, but actually that's going to change, and it's going to also include BRCA positive very soon. So these are the types of studies that you want to be talking to your doctors about. I also want to mention, because sometimes we find that people are on the calls with different types of genetic mutations, is that we understood BRCA1 and 2 reasonably well, but there are other genes associated with cancer risk, and those include things like PALB2, CHEK2, and ATM. And in some cases, we are doing what we call panel testing, looking at multiple genes. And so we're still working out exactly how best to care for individuals with mutations in these genes, but we are actively working on that. And importantly, if you already know that you have a BRCA1 or 2 mutation, you don't need to be retested for these mutations because you're already being managed at high risk, and it's also extremely unlikely that you have a mutation in a different gene. So let's talk about different types of support. I want to make sure we have adequate time for questions. But we do know that individuals and families facing hereditary cancer have unique informational and support needs. And there are many organizations that are aiming to help people face cancer, and specifically those that are geared towards a hereditary cancer risk. There are peer-to-peer support systems, local support groups, annual conferences and events, and some groups have a specialized focus as well. So some of the things here are, we know that FORCE, Facing Our Risk of Cancer Empowered, is one group that has been very valuable. The Young Survivor Coalition can help women with breast cancer who are young. Bright Pink is another organization that's specifically looking at high-risk women who have, for instance, BRCA1 and 2 mutations. And again, FORCE, which is Facing Our Risk of Cancer Empowered. The HIS support group is supporting men with breast cancer, Living Beyond Breast Cancer, Sharsheret, which is for breast cancer in the Jewish community, and the Vassar Research Center. We have information on our website as well. So lots of resources, and all these groups have sort of a slightly different bent, and it can be that one is a better fit than some others. There's an event on October 9th for a breast cancer breakthroughs for young women, and this is the information here that you can check out, and there's the conference can be live streamed on the day of the conference, which is next Friday, October 9th. So additional information on genetic referrals, education, our research registry, things like that can be found at Vassar.org, where we can have a lot of the information available as well. So we really hope to be valuable. All right, so with that, I'm going to try to answer some questions here. One of the questions was related to mammography and whether or not there's concern about mammograms and radiation exposure in BRCA mutation carriers. So the short answer to this is that any potential risk that has been seen in these studies has been largely focused on radiation exposure before age 20 when you look at this. And the data are not prospective. These are retrospective cohort studies, but basically the summary is, kids should avoid getting radiation no matter what unless they really need it. So it's fair as parents to sort of be always asking the question, does my child really need that chest x-ray? And sometimes they do, and it's medically quite important that they get it, but it's always worth asking the question. Related to mammograms specifically, we've never done mammograms before age 25 except in exceptional situations. Right now, between 25 and 30, the guidelines have been altered to say that MRI alone is likely sufficient in that case. And the reason the guidelines were changed were for a few reasons. One is that mammograms don't help us much in that age group, meaning that the breast density is very dense. You can't see much. Second, the risk of developing breast cancer, as I showed earlier, is really small. And third, again, there's a theoretical but not really proven risk of radiation exposure. And so therefore, these days, mostly we're starting mammograms at age 30, and in that case, the feeling is that the benefit of potential early detection outweighs any potential risk. And we do generally alternate mammogram and MRI so that you're getting one of those tests every 6 months from the age of 30. There's going to be additional risk additional research is looking at that. So the second question is, when will research come to fruition that can subcharacterize BRCA mutations so that each individual risk profile can be more clearly determined? This is a great question. So what do we mean by this? Well, we have always long known that all BRCA1 mutation carriers don't have the same risk. We've already talked about the fact that there's ranges of risk, and even though you might hear this lifetime risk of 87%, that's the highest risk ever reported, and actually not one that anyone really uses to quote anymore, because from a scientific standpoint, there are reasons that number's too high. So we know that even within the same family, some people get breast cancer and some people don't. So why is that? Well, of course, there are these lifestyle components. They may have some impact, but we also know that there are other genetic contributions, and we call these single nucleotide polymorphisms, or SNPs. And these are very small changes in genes that only very mildly impact risk. But we now know about 100 of them. So if you will, in BRCA, particularly 2 mutation carriers who have all the high-risk SNPs, they have a higher risk of breast cancer than BRCA2 mutation carriers who have all the low-risk SNPs. The question that we're still working on is how far we can spread those two apart, meaning if all we can do is say that you have a lifetime risk of 40% and you have a lifetime risk of 70%, that may not be sufficient to necessarily change anybody's mind about what they want to do. So we're literally trying to look for differences between like 20% and 80%. And actually, we're working on all that. So when you ask how close, I see us doing studies in the clinic within 5 years to actually figure out how this information gets used practically. So that's my answer. We're in the midst of trying to validate that information now, but it's not ready for use right now, but with appropriate validation, I think that we can start. Okay, another question was this oophorectomy question about the ages. And again, I really feel that, so whether 35, should it even be younger, unless there's some exceptional situation, 35, even for BRCA1 carriers, is the recommendation, because remember, there's harm that you do removing the ovaries very early. And again, BRCA2 carriers can generally wait longer than that. But of course, it's individualized in terms of an individual preference. Finally, it's gotten a little complicated lately because some of the ways that we treat breast cancer are actually to shut ovaries off, and so sometimes that can be an additional kind of complicating factor. The next question is related to OVA1. OVA1 is something that hasn't been particularly helpful for screening. It is a little bit more helpful that if someone has sort of an ovarian mass on an ultrasound, that can sometimes help differentiate whether that is particularly worrisome or not, but it has not been shown to be useful in screening as yet. All right, let's see. All right, is it harder to get pregnant with a BRCA1 or BRCA2 mutation? This is actually a really good question, and the attempt to be succinct answer is, in general, no. Whether there is a relatively slightly lower pregnancy rate remains, that is something people talk about, but in general, it's not felt to impair fertility. So again, I'm reading through the questions. There's a lot of them, and I'm trying to get to all of them. Someone asked the question about if you have both a BRCA1 and a BRCA2 mutation. This does happen. It most commonly happens in the Ashkenazi Jewish population because, again, these mutations are more common. And if you will, you get the risks from BRCA1 and the risks from BRCA2, but you don't get worse breast cancer risk. So meaning you have the risk of BRCA1-related breast cancer, the risk of BRCA1-related ovarian cancer, but you also get the risk of BRCA2 pancreatic cancer, if you will. But it is actually a reason why in the Jewish population, even if your sister has a known mutation, we don't just check for that single word. We look for all three of the common Jewish founder mutations because it is more common. Okay. I hope that I answered the fallopian tube question to people's satisfaction. So I'm going to keep going because there's a lot of questions on that, and I think that they came in earlier. There's a question about hysterectomy. So again, when we talk about oophorectomy, we're talking about removal of the ovaries and fallopian tubes, and we know that that is the key to decreasing ovarian cancer risk. The question of whether or not you need your uterus removed is more complicated, and the basic answer to it is no, that it doesn't fall into the same category. The ovaries and fallopian tubes are the priority. However, why would you consider removing your uterus? One is that there's a theoretical concern about the little end of the fallopian tube that's stuck to the uterine wall becoming cancerous, but that is a theoretical concern that hasn't necessarily been borne out. Two is there has been discussion about whether or not there's a small increased risk of uterine cancer in BRCA1 particular mutation carriers. However, that lifetime risk appears to be about 2% at 10 years. So even if there is a slight increased risk, it is small. A third potential reason to think about having the uterus removed is that it can simplify hormone replacement therapy. So there's that. On the other side of the coin, why not do it? It is a bigger procedure. Therefore, it has a higher complication rate and a longer recovery time. So this is a very individualized decision depending on a lot of different factors, and it's really important to go through that. There's another question about whether you can use hormone replacement therapy if you've had breast cancer and had a double mastectomy. So the issue here is that if you've had a bilateral mastectomy, you don't have you have minimal breast tissue at risk in the breast area. But the concern is always whether or not if you give hormone replacement therapy, you can make little cells that might have escaped the breast turn into breast cancers if you've already had a history of breast cancer. So it depends. The devil is, as you can imagine, in the details here too. If you've had sort of a non-invasive cancer or if you've had a small estrogen receptor negative cancer, sometimes doctors will consider giving hormone replacement therapy, but generally not for invasive hormone receptor positive cancer. Then we try other things. So it's important to talk to your doctor about your specific type of cancer and whether those things are options. Okay. Again, lots of questions, so I'm going quickly. This is a great question. So should a person with a known BRCA mutation be an organ donor? And to this I would say yes, because if you will, you don't donate your breasts and your ovaries, and there are really no substantive risks of kidney cancer or lung cancer or things like, or heart cancer, and those are the organs that are most at risk. I did actually receive a call, one day from a transplant surgeon with this exact question. And in my mind, particularly in someone who's never had a cancer, I feel like there's no, and given the very limited supply of organ donors out there, I don't think this should be a contraindication. There's several questions on breast screening. So the MRI right now is the gold standard tool for breast screening. It is the best test that we have. We do also do mammography on that 6-month interval because in order to potentially find any cancers that might be missed sort of in the middle. There are ongoing studies about whether 3D mammograms or tomosynthesis, those are words that are used interchangeably, is better than a traditional digital mammogram. And it's possible that they are a little better, but if you're getting an MRI, the added value to that 6-month interval tomosynthesis above your annual MRI is going to be pretty small. Likewise, there's really been no data that if you're already getting a breast MRI once a year, that adding ultrasound to your mammogram is specifically useful. And we just don't have adequate data on thermography yet. It is a reminder that for all the bashing that mammograms get out there, mammograms are the only screening study that has been demonstrated to reduce mortality related to breast cancer. MRIs have never been shown to do that. They're extrapolated to do that, and we can make a reasonable argument about why we think they do that, but that is why we continue to use mammograms and add the MRI on top of it. Okay, at what age should you consider having your children tested for the BRCA mutation? So the short answer is that there are no known increased risk of childhood cancer, and this has been looked at, and it's really not seen. That doesn't mean that sometimes there aren't childhood cancers that occur in families, but there does not seem to be an increased risk compared to the general population. And therefore, we advise that your children get to be adults and make their own decision about when they want to be tested, because there's nothing that we're going to do in childhood that's going to be different for them. For instance, we're still going to want them to, eat well and healthy and get lots of exercise and not be boiling and baking in the sun all the time. So in general, we talk to people when they're 18, but for women, we generally say testing at 25 makes sense because that's actually when we're going to initiate screening. For men, we, as you saw, we don't really do much for them till they're around 40, but if they're going to use this information for reproductive purposes, like for instance, for pre-implantation genetic diagnostics, then we would do it earlier. So I hope that answers that question because it's really important. Someone asked about what I tried to show, that decade interval risk, and yes, people are very interested in trying to quantify the risk from, if you will, sort of every 5 years to get a better sense. Another person asked that her genetic counselor gave her somewhat different percentages than I gave, and you know what? That is one of the challenges. There are some models that people use, something called Bodicea, which can try to factor in different things, including your family history, to come up with an estimation on breast and ovarian cancer risk. But again, as discussed before, we need to do a lot more validation about whether these more individualized risk assessment would be valid. Let me see. Whoops, am I running out of time? I'm going to answer one more. Okay. Let's see. I'm going to try to pick a good one. So, someone asked this question again about whether that there's no ovarian cancer in the family and all the breast cancers occurred at 50 or later. What is the risk? So again, you've heard a range because there is a range, and unfortunately, no one's going to be able to do better than that right now until we get more individualized risk assessment. And again, we are very much looking at that. Again, I couldn't answer all the questions. We had a ton. That's good. I think that next time we'll learn and we'll give even a little bit more time for questions, but hopefully I answered most of them. So Pam, I think you had a few closing comments.
Yes, thank you, Dr. Domchek. So we are unfortunately out of time for today. Today's presentation will be archived and available for viewing. The link will be posted to basser.org /webinar this week. We will also announce when the link is available on our Facebook page, and we will also post a date and topic for our winter webinar on Facebook as well as our website, basser.org. Thank you to Dr. Edward and Merry Prostic for making this webinar possible, and to our support partners, the Young Survival Coalition and Bright Pink. Enjoy the rest of your day.